Okay, welcome everyone to this episode in our series of webinars and podcasts developed in partnership with Wellspect and ISCoS. My name's Alan Cook. I'm the marketing manager for Wellspect UK, and I'll be your guest host today. Today we're going to be discussing intermittent catheterisation and how to succeed with bladder management. We'll be covering three main learning objectives, so key factors to consider when starting ISC, addressing potential barriers to success, and maximising compliance after discharge. Now, my interest in this topic is not just from a professional perspective. I sustained a T8 complete spinal cord injury in 2005 and was taught intermittent catheterisation during my rehab. I've now been successfully managing my bladder with ISC for about 17 years. I'm honoured to be joined today by three clinicians with huge knowledge and experience in this area. Rachel Skews, Kim Porter, Jeanette Jones. Thank you all for joining us. Rachel, would you like to start off by giving us a bit of an introduction to yourself?
Thank you, Alan. Thanks for inviting me. I'm Rachel Skews. I'm a urology nurse practitioner in Bristol. I do everything, all things dysfunctional, so sexual dysfunction and bladder dysfunction in men and women. I feel like I've been doing this forever. I absolutely love my job. Very passionate about what I do and what we can do as a community of nurses and medics and industry to help our patients. Thanks for inviting me.
Great. And Kim?
Hi, I'm Kim Porter. I've just finished a role of 15 years on the spinal unit, and I've just moved into the outpatient department to do an advanced clinical practitioner role in urology and outpatients, but specialising in cord equina. So I will just be moving my skills from the 15 years of teaching patients on the ward with ISC to problems found in outpatients and the cord equina patients coming in new that need additional information. So yeah, really interested in this role. So yeah, thanks for inviting me.
Great, thanks. Jeanette.
Hi, my name's Jeanette Jones, and I'm working on the spinal injury unit where I've been a healthcare assistant since 1988, and part of my role is to teach ISC.
Brilliant, thanks. Well, thank you again all for joining me. I think it's going to be a really interesting conversation. I think when we've spoken before, we could talk for hours on this one, so we're going to have to sort of curtail ourselves a little bit and try and state the topic. So on that first topic, key factors to consider when starting intermittent catheterisation. Thinking about that very first process, that first starting ISC with a patient. Thinking about when's it right to approach and how would you say is the right time to start ISC with a patient? Who wants to start? It's slightly different as well with your different roles and the different positions in hospitals you guys have got. So Kim, from a spinal injuries unit perspective.
Okay, so generally, because we don't wait for our patients to be able to do it themselves, we try and bring in the gold standard of intermittent catheterisation straight off. So it's usually within 24 hours of admission. And then we get them through the process of understanding how we do it to maintain their bladder management, to get their tone back of their bladder, to ensure that we're reducing the infection risk by not having a catheter in there all the time. And then because they're watching us doing it and we're doing it on such a regular basis, it try to make it more a normality for them, so that when they've had their patient education and they've started either mobilising or being able to sit up so they can actually do it themselves, then we start assessing dexterity to see whether we can transition to patient-led intermittent catheterisation. And that's all around them becoming independent and self-care for that, that time frame. I mean, some patients are slightly different. If I need any fluid balance monitoring, of course, I'm going to leave the Foleys in for a bit longer. Or if we're finding that there's trauma or there's underlying medical conditions. We don't generally say no for a prostate, but we do need to have a good understanding of what their prostate history is so that we're not causing any harm. We have had a lot of issues with false passages and things like that, so we have to take that into consideration. Luckily, in line with Jeanette, she's got lovely links with all the catheter companies. So we do have a lot of information from different catheter companies of what we can access to make sure it's the best, because originally 15 years ago we were using one catheter and everybody had the same, whereas now we have a whole market of catheters, and catheters with kinks, catheters with extra lubrication, you name it. So there's never we don't start it, we just need to maybe adapt our way that we do it with all the products that we've got available for us. So it's generally as long as we've got patient's permission and consent, then the nurse will start it first, and then it leads on to good education, appropriate equipment, and the consent and understanding of the patient that they're going to be with us on this role, and that we're there for them, and that we're going to supervise them, intervene as necessary, make sure their technique's good, but the earliest as possible we will intervene with intermittent catheterisation.
And Rachel, from your side of things, because yours is not
and that Kim, that sounds absolutely amazing. Obviously, I'm in a slightly different position where I get people call me from the wards to ask for advice regarding this sort of thing, but I am based in outpatients. So I will go and see patients on the wards, but we've got specialist nurses on the spinal unit who teach the patients, but their emphasis is is on bladder and bowel, but they don't have they're not specific urology nurses. They're neuro nurses specifically, and although I've taught them how to teach self-catheterization, etc., there are only 2 of them, and it makes it a little bit more of a challenge to teach the self-catheterizing early on. And that sounds really inspirational, Kim, and I'm going to talk to my trust about that. And the difficulty is we're not a spinal unit. We are it's a large tertiary trust, don't get me wrong, and more of our patients are staying for quite a long time before they're getting to their rehab place because of COVID, because of all the other challenges that are in the NHS at the moment. And it means that they're staying longer with us. So more and more of those patients are being taught, but the facilities and the structure that's needed isn't in place yet. And that's really, really important. But how they start that conversation is talking about the problems that can be caused by the catheter, the irritation, the pain, the discomfort, the future of potentially being able to, making intercourse easier, being able to wear shorts, sports, all the things that are advantageous using self-catheterizers. They sort of get that conversation going, and it might be because that's some of the challenges. And they were telling me about a young 19-year-old boy who they've got at the moment who won't acknowledge his waist below. He won't acknowledge that it exists, and these are the challenges. So not only the bladder management, and he won't open his tap, he won't use a flip flow valve, he won't do anything because he won't acknowledge his waist and below currently. So I suppose it's not just the physicalness of teaching ISC and talking about it, it's a psychology, isn't it, of it as well, isn't it? It's the psychology of such a thing. And I think that's what they are saying, were telling me, and I found that myself as one of the biggest challenges of even starting a conversation about it.
Yeah.
It's so personal.
It's an interesting one, actually. I mean, Jeanette, with your experience in this one, you've seen lots of people who are struggling with coming to terms with doing this. And I think actually possibly in your unit, it's because you guys started nurse-led so early on. I mean, it's one of those things that I already noticed within spinal injuries centres, and it was the same when I went through my rehabilitation. Everybody else was doing the same thing. So there's always somebody going down that journey a little bit ahead of you, there's somebody a little bit behind you. but it was always it was a given that somebody at my injury level was going to go into ISC. So it was never really a challenging, it was kind of always just a given. It was never a thought that I had to go, oh, I don't know if I'm going to make this decision or not. But even with that, you still get a lot of people who are quite reluctant to do it. And Jeanette, I'm sure you've seen plenty of people from that psychological side of things are just not switched on to doing this at all, don't take it on.
Yeah, definitely. There is a lot of patients with psychological issues, but it's just, and other patients, as you say, help overcome that because, especially with the catheterization, they'll encourage them to try the catheters that they're currently using, and explain how it's easy to use and the difficulties that they've overcome with it. So definitely.
And I guess from what we're discussing as well, there's no right time to start this as such. There's no sort of, okay, right, there's 6 weeks post-injury, now it's time we start ISC. It's very individual for every single person.
And for me, I tend to get involved further down the line when there may be problems, and or the wards may call me because they need a more variety, because I'm in a position where I've got many more catheters available to me. I'm based in the outpatient, so I've got, with me and the outpatient nurse, have got a big cupboard full of different catheters and different lengths and different types and different coatings, and actually on the wards that they're limited to the space they've got, and they've got the basics, and it may be, actually, we've got this young lad, or we've got this female, or we've got that, they're really struggling with this side of things, and and like you say, Kim, earlier, there's so many different catheters on the market with so many different coatings and coverings, and there's always something, and that's why we are so lucky nowadays. There's always something there that will be able to help our patients. It's just that knowledge that we have of the different catheters that are available and of the different barriers that may be there, and having the opportunity to share that and take those catheters up to the ward and either show the patient or show the nurse, depending on what the situation is. And can I just raise something? Our problem is on our ward is it's a super duper, one of these super duper hospitals, the PFIs. They're all individual wards, rooms. So they've got their own room with their own shower and stuff. They don't have the opportunity to talk to other patients. There is no day room. There is no chatting in the night when they can't sleep. There is no shouting over to John, oh, you're all right, how are you this morning, mate? Like I've always worked on wards where there's at least 6 in a bay, and that opportunity of chatting to each other and learning from each other doesn't happen. And although infection control wise and peace wise it's good, I think that community and that recovering together, we miss that opportunity in Bristol.
I totally agree. I think I'll let Jeanette answer the end of this, but the difference from I'm on an acute side, and that's where I've been for the last 4 years, but you find the patients become very blinkered to what's happening around them, and it's very individualized, that it's just me, nobody else is going through the same situation as me. They don't understand, and then they move into a double bay and they start having a bit of camaraderie, and discussions start happening. And then Jeanette, do you agree that when they move over to Gladstone, totally different thing?
Definitely, because when they're on Gladstone, usually they're in about a bay of 4, and as they progress through the rehab, they move down the ward, so they're mixing with different patients, and they get to the stage where they're chatting over stuff. I mean, they'll even chat about their bowel care and bowel results. That's how close they get over meals. They're quite open with each other. They'll chat about all sorts, and like I said about the catheters, they'll all chat about different ones, what's on, what suits them, the difficulties they've had with it, and it's like, because it's the problems, like it's because some people might like have low education and things like that, so they need a lot more encouragement. But it's definitely, and I think it's a good thing being in a bay of 4, definitely, to help each other.
If you'd asked me when I was going through my rehab of whether I would prefer to have a side room or would have to stay in a 6-bed bay that I was in, I think I would have bitten your hand off to have the side room. But in hindsight, it was the best thing ever, was being in that 6 bed. And we were the same. We went through that kind of, as you've said, Jeanette, going through different rooms, you get to see different people. But it is absolutely that peer support. And I mean, there's a lot of dark humor as well amongst it that you've all seen. But that's how you get through it. And it's, I don't think I would have stuck to half of the therapy had I not had that sort of positive reinforcement those times when you're struggling, or the little tips and tricks that comes in from everybody else, where it's just a little technique or a little thing, or just visualizing something about how you're going to move on with your life post-discharge. And that added to just peer support coming in, I think it's a really, really powerful tool. And I think there is a drive in some sectors towards with newer hospitals to go down this side room or single rooms, and we've just got to balance that right with the real power that comes from peer side of things. It's huge.
And I think if somebody's a little bit low in mood, or because people are, they help pick each other up. Whereas if you're in the side room, you're quite isolated, and it's quite easy to sink into a low mood. So I do think they do help and jolly each other along, being in a 4-bed.
Yeah, definitely. I mean, there's always the downside as well. When there's only a curtain between you and the next person to getting their bowels done at 6 a.m, there is negative sides to it too. So, but thinking about, I mean, sort of moving on from the psychological side of things, on the physical barriers part, just thinking about different injury levels, particularly on sort of hand dexterity, body size, the shifting demographics in spinal cord injury now, where we're a lot more older injuries now, a lot more incompletes. Anything anybody wants to sort of bring in the particular challenges around that they bring towards doing intermittent catheterization?
It's the issue of clothing. It's the daily routine of doing it all. It's trying to work out how you're going to fit that into your work-life balance when you're discharged. It's the psychological issues, because a lot of men, to start with, when they see the size of a catheter, really don't want to be performing that every 4 hours. Like you say, it's dexterity, it's their health, their age, the level of injury. So it's a lot of things to consider when you're thinking of doing ISC.
And I think that we're really lucky nowadays with the different breadth of catheters that we've got available to us, the self catheters, and like I've already said, the different coatings, the sheath coverings, the grippers, the different tips that are available, and like you say, they've got to be easily usable so that men and women can get out and about. If they've been told they've got to catheterize every 4 hours, but they're at college, they're at work, they're out and about, they're at the beach, they're at a nightclub, they're at a concert, whatever they've got has got to be usable in the circumstances that they're at. So the more and that's, I think, that's really, really important for our patients. It's got to be individualized. It absolutely has to be individualized, and that's why it's so important to show them so our patients lots of different, but don't overwhelm them. So it's really difficult getting that balance, isn't it, of not overwhelming them, but giving our patients the access to the instruments, the tools that they need. But you've got to do that in their time, in their space, and that changes. So what they need maybe in hospital, and what they maybe need in the rehab unit, and what they need at first when going home will be different in 2 years' time, 4 years' time, 6 years' time. Body habitus changes, pregnancy, menopause, all the different things that physically, as adult, as a grown, as we change, means that you'll have to have different products and different ways of getting challenges. And that's where we as specialists come into it and should be there for our patients and for each other, because Kim and Jeanette are in a much better position with the acute patients. I'm way down the line, whereas Kim and Jeanette are so important for these, where it's boom, they've just had this injury. how are we going to manage? How are we going to cope? I'm in a lucky position in a sense, because I'm way down the road. I'm in a position where they're already sort of there. They're already doing it regularly. It might be just hints, tips, changing products, just moving things slightly around. Whereas you guys are, dealing with, it must be so difficult for you and for your patients, having to have that conversation, bearing in mind all the other things that they're being challenged with at the moment.
I think it's the rawness that we start off with, that, they've just had this life-changing injury. And then, we are saying that, your life will change. It's going to move on. We're still going to move forward. We're still going to get you back to work or get you back to college, get you home with your family is our main aim. But you've now got to intervene with that. You will be doing your bladder and bowel care, and it's getting them over those hurdles, because you've always and then you've got the ethnic and religious side of it as well, which always knocks us for six when we get one that, oh right, okay, left hand, right hand, can't do that, how are we going to work that out? We've got a gentleman that is just adamant that his two wives are going to take over his care, so why should he bother rehabbing? And it's all about empowering them to be, at least to direct their care, to do it while they're here, so that if that system falls away, then they've got those skills. But it's like Jeanette said, it's getting them over that hurdle of putting that, what they consider a very large tube, into their bladder. Things don't go in, they're supposed to come out, is what the saying is, and the same doing with their bowels. You want me to put my hand where? And it's doing it just slowly but repetitively, that this, unfortunately, this is your now new norm. But to then look at the benefits of, you can come independent, you can carry on with your normal life, and that if you get this done yourself in the morning, you can move on, that's it, it's done. But then you don't have those 4 different carers coming in a week that are going to do it for you. You can do it yourself. And I think it's just finding those ways of motivating them to move forward, but still having that understanding that this is massive to them. We take it, we do it every day. It's Jeanette and I say most of us probably can have a conversation about bladder and bowels over our steak and chips. It really wouldn't. Chocolate mousse wouldn't bother us at all. But to them, they haven't got to that stage yet. They might by what we say, it starts at bay A and they go all the way down to bay G. But by bay G, they might have that conversation. But when you're starting them with the acute side, especially on my side of the ward, that they're really not ready. And sometimes they don't always get your jokes. But we do try and use humour a lot. You just have to remember, I think, the cultural bit, because it's very hard to explain a joke if they don't get that, they don't understand your cultural reference to those things. And sometimes communication is key point, in that we have a lot of different nationalities. We've had a lot of immigrants lately, and that has really tested our skills of communication to make sure they have that understanding, and we're using the correct language, and sometimes using different communication styles, pictures, things like that are valuable. But sometimes you just have to think otherwise and out of the box to move them forward.
Jeanette.
I think as well, when they're doing their own ISC, a lot of it is body image as well, because when they're newly injured, a lot of people don't want to have a catheter, because of personal relationship side of it. So a lot of them, you're using that, not using that, but you're helping people along, because the last thing they want to have is a suprapubic catheter or an indwelling catheter.
Yeah, absolutely. And I think, it's one of those things from my experience on it, there is so much stuff going on in the acute phase of spinal injury. And there's just the biggest juggle ever to try and somehow visualize that there's any form of life, let alone an independent life coming at the end of this. And you just can't really picture how that's going to look. None of it. I mean, housing, job, relationships, just aging, everything is just so up in the air. And then you're trying to fit this thing into it. I mean, the only thing that really pushed me towards it, just is kind of to that point you made, Jeanette, is that it was that concept of having that catheter stuck in me all the time and a leg bag on, like wearing shorts. I was a young guy, so still very obsessed with body image at that age. And that was probably the thing that pushed me on. But I guess that's probably even more of a challenge now with an aging demographic in spinal injury, that some of those drivers are maybe not as big as before. But it's definitely the psychological side of it. The other one as well is that, and this is an interesting dynamic between what you guys, Kim and Jeanette, do and the spinal unit to what you've got, Rachel, is that in the spinal unit, everybody's aware of the process. Everybody knows that we're going to be going down the road of intermittent catheterization. So it's kind of reinforced all the way through it. As much as there's one individual person that taught you how to do it, everybody, every other nurse, every healthcare assistant, even the physios and OTs all know the process. So it's just, if you've got any doubts or concerns, it's just positively reinforced all the way through. Whereas I guess that's probably more of a challenge with your patients, Rachel, because they're not going to get that positive reinforcement all the time.
Absolutely, yeah, and it's not it's a neuro ward. We don't have a spinal cord injuries ward in NBT at the moment, but we do have rehabilitation centres around where our patients go to for their rehab. But like I already said before, there are considerable waits for these beds at the moment because of the world that we're in at the moment, and I think that's had to change how those ward nurses are working and how the neurology nurses are working, because the patients are staying up to 6 weeks in an acute bed because of that situation, and it's and we haven't necessarily didn't necessarily have those facilities to get rehab going, and that's had to be a bit of a change in that department, and changing the mentality of the staff as well, because they've been used to dealing with the acute, the sick patients, and may have just about started the ball rolling regarding the catheters, intermittent catheters. Most of the time the neuro nurse was saying that they were transferring with an indwelling, but now they're having to get the self catheters going, and the bowel management, etc., are going now, and that's been a whole change in the culture on the ward and the education for them. So we as urology nurses are being relied on more, which is no problem at all, but it's really, really interesting. And like you say also, Alan, the change in age group of our patients, and Kim, the change in the ethnicity of our patients is huge, and the interesting injuries that are coming in now, and what people are surviving as well. There's people are surviving much more complicated in accidents and injuries, and what the care that they require is more, and the dexterity, but that also helps with the different catheters that are available. We're able to teach patients who have got much bigger injuries how to self-catheterize because of the different products that are now available to us, and the change in how the catheters are made, the coverings, the sheaths, the grippers, and all the different things that are available to our men and women, make it easier to teach these patients with bigger injuries because there's more available.
I think especially the aids as well that are supplied. I mean, it's fantastic, all the catheters that are supplied, but all the different aids now that are around are a huge help, because that also encourages them to be able to do it themselves. Like you're saying, the grippers, the mirrors, all the different things are about to help, especially the ladies. It's fantastic. And the high lesions. Yeah, definitely.
And I think in the West Midlands, so our nurse consultant is developing links within each trauma unit, so the QE and so on, to have teams of liaisons that are specialists in spinal injuries for us, that are going to intervene earlier because of these issues. And I think it will, because you're lucky in the fact that they are stepping in that early. Ours aren't. Ours are still coming after 6-7+ weeks with catheters in situ, no great bowel routine, even though, they've been given the spinal document. It tells you what to do. You've got your link on the phone who will do visits as well. But now each individual trauma centres are going to have their own teams that hopefully are then going to go to each individual wards after they've had their individual training to then try and get this in earlier. So like you, Rachel, you go in and, nurses on the wards are doing it in neuro rehab. We need to get into these acute hospitals that are having to keep these patients a lot longer and intervene with this, because, we're finding that unfortunately we're already dealing with 2+ infections by the time they come to us.
Right.
And it has a massive knock-on effect for their future, so gold standard is that, we don't keep these catheters in for this length of time when there is an alternative.
Yeah.
So
it's an interesting one, actually. This is something we see more and more. We know there's a lot of patients who simply just don't get your spinal centers as well. So there's no guarantee you're going to get admitted if you have a spinal cord injury. But then, I guess with those waiting times to come in and those patients that don't make it, is trying to make sure that they still get that opportunity to go into catheterization. That's going to require training and teaching from dedicated teams that don't necessarily have that experience or don't have a Rachel in a team nearby that can come and do that training. So it's a real challenge, and I know that certainly in the UK, the spinal charities are really focused on trying to provide support there as well, because to get that peer support element back in. But I would say, obviously, it's definitely one motivator that for me was having a shocking UTI before starting catheterization, because there's nothing like a bad UTI to want you to try something different. So it's a good motivator. Not that I'm suggesting it's a protocol we should use as standard, but it definitely does help.
Just secretly go to our patients that don't want to be outrageous.
Would you like to see the symptoms? Yes.
Yeah.
But they don't believe you until they have one. How bad it can actually be and how ill they feel, and that actually this bladder management technique might improve your risk of not having a UTI. It's just something that nurse flows about, isn't it? She's always moaning about it. You should be doing your intermittents more regularly. And then they have one and they're like going, no, maybe you were kind of right. Yeah. You're not going, yeah, it only took 15 years.
Yeah, I know one young lad who thought he was going to die because he got a UTI. And we were saying, you've just got a urine infection. And he was like, no, I'm not going to be here tomorrow. And we're like, no, you've got a urine infection. I said, this is why you must do your catheters. And this is why you must have a clean technique, because you've got a UTI.
Yeah. And I suppose it's that peer support, isn't it, that you get in the spinal cord units. And I know that we've spoken about that before. And that's what's lacking in the acute trust. And a 6-week stay in an acute trust waiting for a rehab unit must really change the outcome, mustn't it? You think you hope it won't, but there is that definite possibility, isn't there? What can we do about that? That's so
I think
big,
I think we've got good links with our peer supports, and COVID has been horrendous, but before, if we had any issues with long stay patients in an acute trust, that used to be 2 to 3 weeks, and now we're talking 6+ weeks. They will go out and see them and then give us feedback on, what is actually happening there, what are their main fears. And it does really help to get them in there quick, even in an acute trust, and that, still on bed rest or whatever, just to see there is some light at the end of the tunnel, and then show them the way, and that they've coped and they've moved on. I think the peer support is invaluable.
Yeah. I think it's, the other part from it now, thinking back to the 17 years ago when I was injured, is that the transformation now is that, yes, we've got bigger peer support teams, but we've also got huge online communities. and then that's the place you first go to for asking for advice. So there's, as much as COVID has really limited the physical peer support presence, I think it's really boosted the online communities that exist. And I mean, it comes on to our sort of next point is that how that carries on for the rest of your life, that level of support. So it's just, our last part to talk about was thinking about the discharge and follow-up and maintaining adherence and compliance to therapy. And I think personally that part's been huge. Being able to be part of that spinal community long term has meant that challenges that come up, you tend to have, even if you don't necessarily have the tools to address it there and then, you know where you can go and ask for them. But equally, that's something I know that Kim and Jeanette, certainly from the spinal centre part, is that long-term follow-up is something that's really key. So you guys got any kind of advice on that, ensuring compliance long-term, and that's once you've gone discharged to home?
Yeah, I mean, luckily, I mean, before they go home, on all the walls down the corridor is all the charitable associations and their leaflets. They have regular drop-in sessions with their peers, so their contacts are kind of made for that support system. But then we bring them back pretty regularly just in the first 12 months. So we'll start initially with a 6-week review. They get a phone call after they've gone home after a couple of days anyway. Jeanette liaises with them intensely over their orders for their catheters and things like that, and set them up on whatever system, whether it's a GP system or whether it's an online service. Then we'll, depending whether we take them home, because sometimes if we take them home, that we have a handover to their carers and that we can settle them in personally. So we've got a good idea of whether, do we need to give them a phone call sooner rather than later. Then we bring them back at 6 weeks and try and identify, so it's a full assessment on everything, their bladders, their bowels, their pain, a full neuro, just to check whether there's any changes since admission. And then that's when initially we will pick up any major problems, or have they had a urine infection in that 6 weeks? What have you done differently from your catheter care that you did while you were on the ward, because you were free of infections then and you're not now? So what's changed? Maybe sometimes we'll check their technique, ask them whether they'll do a catheter in front of us, or we'll just do a bladder scan post catheterization. Are they retaining? Is something different that way? So it's picking up them, and then we're, based on that 6 week, what intervention we required then is whether we do 3 months, 6 months, 12 months, and then go yearly from there. They have ultrasound and before they leave us, so that we have a baseline at the start of injury, and then we repeat that when they come back, so that we can catch stones early or catch any reflux. We do urodynamics on them if they are on intermittents prior to them leaving. And then we do cystoscopies annually to 2 yearly, depending on their medical history. But like our outpatients department has a phone line, so they're told that they are with us for life for their spinal injury, so that they can phone us, so that in outpatient it is just a phone line. They can leave a message or we'll answer it if it's manned. And then that is diverted to the ward out of hours. So if they do have any issues, they know that we've not left them, we've not just sent them home. Bye-bye, I'll see you in 6 weeks. They have still got that contact to get to us. And we try and, tell them that, however small it is, just give us that call and we will try and address those issues early, so we don't get to the stage of a urine infection, but you do find in that 6 week period that you probably won't have any contact with them. It'll be after that, once they've come to you, found that, oh gosh, actually I've had this problem and that problem, and we can try and sort it. Then they think, oh, well, that's all I needed to do. I just needed to pick up that phone. But initially they just want away from us, don't they? So they just want that freedom of being at home and the peace and quiet from, the normal routine of a ward and 5 other patients or 4 other patients having their bowels done next year and I don't want to speak to those nurses. They're very naggy.
Not at all.
Not at all.
Patience with
Persistent.
everything.
Yeah. And I think that's definitely a support system we do.
I think because you've built up such a good relationship with them while they're on the unit, because they're in for so long, they feel they can pick up the phone and speak to you, and they know that you are going to help them. And as well, what's really good is some of the delivery services that you're setting the patients up with. If the patient, for some reason, isn't ordering catheters or has stopped ordering the amount of catheters, they'll get in touch with you too. And it's good as well that they'll give the patients phone calls, like we're saying, if people have got memory or whatever issues, they'll give the patients a call to make sure that they are having that supply of catheters, so you know that they're safe there, that they're being backed up there. That's really good.
Yeah, that is really good, isn't it? And I'm in a position where I sort of see people down the road. So I do their Botox. So I'm in a really everyone thinks it's great giving Botox, because people think you're amazing, because they go from being incontinent and having really bothersome LUTs and wetting their clothes and all that horrible side effects of having urgency and detrusor overactivity, etc. And they come in and see me, and they think the sun shines out of my bottom, and it's brilliant. All I do is give them a bit of Botox, and it's absolutely marvelous. And I'm lucky in that sense, because I've got a really good relationship with them that way. And I do a complex connect, which is basically people or men and women that have got complicated urology history, so spinal cord injuries, spina bifida, and cystoplasties, mitrophonophs, all that side of things. So I have annual follow-up with them with EGFRs, kidney function, and ultrasounds anyway. And then they just keep in touch with me. So if they are getting any recurrent urinary tract infections, we can talk about all the different treatments available for their infections, obviously looking at their technique, looking at their catheters, looking, flexible cystoscopies. And I can do all this myself, and that just gives that a bit of reassurance as well. Being a slightly advanced practitioner gives that reassurance. And because the difference is that I'm always there, me and my nursing team are always there, like you and Kim and Janessa, you're always there. We've got registrars that come for a year, 2 years. We've got our consultants, but they're so busy. It's really nice for them to have that regular face, that regular person that, and all they have to do is ring up now and say, oh, is Rach around? And there's only 2 Rachels. So there's little Rach and big Rach. And believe it or not, I'm big Rach and I'm only 5 foot. So there's 2 Rachels, and they just say, and little Rach is more involved in the anorectal side of things, and big Rach is the urology side of things. So, whichever Rach they want, we're always there. And I think that it's the consistency, and it's the trust of knowing that we're available if they need to be. And for you, Kim and Jeanette, I suppose that makes it easier having the ward there. But for us, it's having a good secretarial team as well, having a good background team. I've got really good admin support, and I really trust them, and my patients really trust them as well, that they're gonna be reactive. And I think that's really important, getting the right people around you.
Definitely.
I think from personal experience, within the spinal community, it's generally accepted that healthcare professionals outside of spinal injury don't know the first thing about spinal injury, and that's probably a little unfair. They're very good clinicians, but those that have gone through dedicated spinal treatment centres they're spoiled by the experience and the knowledge that's there, and then you get presented with your GP who doesn't really understand to the same level they do. So that, I can't stress how valuable that's been personally for me, but for loads of other people I've spoken to, about being able to get back in touch with your spinal centre, whether that's through just the regular follow-up procedures that are coming in every year or 18 months for the rest of your life, or whether it's just that ability just to pick up the phone at any time and ask the question. And that's from an ISC perspective, that's definitely kept me more compliant, because I would have probably switched on to other therapies when I started to get problems about 5 years post-discharge, with more regular leaking, more overactivity in my bladder, my body was changing, and just coming back into the likes of Botox, I probably would never have been signposted to that through my GP. It would only be going back through the spinal unit. So I think that this access to, and I know it's a resource-heavy issue, but this access back into spinal centres or into the specialist staff is absolutely crucial, because otherwise you're going to end up referred to the GP. You're going to go to somebody who doesn't really know. You're probably going to end up or run the risk of going back into either suprapubic or just dropping off therapy.
And I suppose geography makes such a difference, doesn't it? I'm just thinking, I live in Bristol, and obviously from the south of us, you know, they're all really small trusts, apart from Derriford, essentially. They're all really small DDHs. And if that's where home is, the opportunities for treatments such as Botox, sacral nerve stimulators, patainial nerve stimulators, etc. You know, you're having to travel hundreds of miles to get this treatment. And like you say, geography really does make a massive difference to some of our patients, doesn't it? That I hadn't really considered.
Yeah, I think definitely with the spinal units, we are very sparsely, you know, placed within the UK. And, you know, I do sometimes think who comes so far to, you know, to visit us just for their appointments. I mean, we have people traveling 2 hours for a suprapubic change because we can't get their community to do it, and they can't get the urology service to do it. So, and I just think that's bizarre. That's a 4-hour round trip for a suprapubic change. You know, we're not okay, we're expertise in our area, but just because they have a dysreflexic attack because you've changed their suprapubic doesn't really mean they need a 4-hour journey to come and change their suprapubic. It's like, how do we get the education out there, isn't it? And then the same with the, you know, we have issues with continence teams taking them over in the community and them getting phone calls going, well, do you really need 6 in a day? Wouldn't 2 do? And you're like going, no, don't let them do that. So then you end up having these conversations with, you know, continence teams, or they go, well, this is a slightly better catheter, and shall we try this? And you're just thinking, oh, you've got them into this lovely routine with this catheter, and it's like, you know, how do we educate the, you know, the continence teams in the community that we've set these patients on intermittent catheters? They're doing them by themselves. They're not asking for intervention from any teams, any carers. Please just leave them with what product they've been given. You know, or at least bring them in, have that conversation and trial it with them. And, you know, I've got a friend I did my master's with, and she's from the Powis Trust, and she is, you know, we learned so much off each other. You know, so I gave her all my knowledge on spine. She's got quite a few spinal patients. Oh, so I won't do that then, and I won't do this. But we'll, you know, and it was a great contact to have and a transition of information. And I think that conversation really needs to go on more. And they'd have a better understanding of our patients, and we'd have a better understanding of how they work, so that we can access them in the community. You know, and maybe that would really help our compliance if we can get to these teams that then take them over in between our you know, 12-month reviews, that deal with them and stop them or start them on different things. I mean, their answer to somebody leaking is to provide them with a pad, but you know, that's not for us, is it? We you know, we'd like the investigations to go on and bring them back and, you know, see what's going wrong. But I do think compliance isn't just for the patient. I think it's the factors surrounding them that are also having an influence on, you know, how they do. If they're not strong enough to resist against that person phoning them up and saying, no, I think you should do this, then you know, the compliance is just going to go back to, oh, well, she must know best, so I'll do that. And all your 6 months of hard work with them is down the pan, isn't it? So
and I suppose, like you say, your job is so important. Yours and Jeanette's job is actually, what is normal? What will they expect? Is it normal to leak a bit? Is it normal to use 3 pads a day? And I suppose, no, it's not normal, and it's not acceptable, and it's not right. And there are stuff that we can do about it, but they need to know that, don't they? And I suppose that's part of your role while they're inpatients, but part of my role as well as an outpatient. How, you know, making sure that when we're following them up, we're asking the right questions. We're asking about their bowels. We're asking about their fluids. We're asking about, their symptoms, their medication, what they're drinking, what they're eating. You know, there's so many different things, but making sure that we are consistent on what we're asking and having the knowledge and keeping ourselves up to date so that we know what's available to help our patients.
Yeah, I think during COVID, or just, to be honest, even up to a month or so ago, a lot of the patients who are going through like their GP or through the pod and all the rest of it, who were using a specific catheter, who trialed it in the unit, and that catheter was what suited that patient, they were then having trouble with deliveries, being able to get it. Well, we just phoned the companies and they were just sending them straight out to them. So, you know, that wasn't an issue then, but that's something that the GP wasn't really doing for the patient. So, but we solved it in the unit.
Yeah. I think we could carry on talking this subject for hours.
Oh, yes.
And actually talking about the peer support side of things, it is definitely something. You get two spinal cord injuries who have never met each other before in a room. Within 10, 15 minutes, you'll be talking about bladders and bowels. It's just a given. But it's been really, really interesting having this conversation. So just to kind of sum up a few things. One thing that I'm really struck about is we started off talking about the factors to consider when we're starting off and when to initiate it. And there's a little bit of an issue there with the kind of pathways in, people not necessarily getting into a spinal center or getting treated really early on. But equally, in this part, we're talking about the importance of follow-up. Both parts are really, really key, that there's clear communication from you guys, you specialists, they know what you're talking about, to those other healthcare professionals who are maybe not quite as switched on or as experienced or as knowledgeable in spinal injury. And the same thing goes for peer support. So there's a real importance to try, or seems a real importance to try and disseminate this information, this knowledge and experience as much as possible. Hopefully this kind of webinar does help towards that. But would you agree that's something that's really, really crucial?
Absolutely. Absolutely. And frightening amounts of nurses, really experienced senior nurses, are retiring at the moment, and retiring early. And when I sat through the Bound conference, it made me realise, and I'm not blowing smoke up my bottom, but how much knowledge I've got. But the danger of the knowledge I've got is in my head. That's the danger. And actually, I haven't created and provided enough pathways and education for nurses to come behind me. And if I, God forbid, got hit by a bus, whole services in my department won't happen, because no one else knows how they work. And that is my fault. That's something I've got to do. I've got to find the time to make pathways, to write down what I'm doing, to make those visible, to make those accessible for other people, and to continue to teach. And I think I am teaching, but my problem is letting go, is delegating, I'm a bit of a control freak. And I do have a team around me, and it's about, and I must, and this is something that I'll take away from today, and I must just share that. And it's not about not wanting other people to do it, but it's just about trusting that other people will do it well.
I think it's the succession planning that we're poor at, isn't it? I mean, our outpatients is full of ladies at retirement age, and the amount of knowledge in that room is just ridiculous. And I keep trying to drag information out of them so that we can move forward. One does sexual function clinic, one does children, one does this, and I'm like, yeah, but who's going to do it when you're all going to leave me? And I mean, I'm 50, so even I haven't got that long till when I could retire. So who's going to have my information? And since doing my masters, it has enforced me to, every time I learn something, I'm then going, I teach somebody else it, so that it's always like passed on. And we are lucky in that we do educate our nurses well, and we are forever updating our knowledge. But I think taking that further, I mean, student nurses now are going to come out so advanced, supposedly, but I do wonder where they're going to go for all this knowledge that they're supposed to be equipped with. I mean, just that they're all supposed to be equipped with manual evacuation techniques and be signed off. I mean, we've recently had a couple of students, and I looked at the documentation. I said that I'm not signing you off unless you do what I expect my staff nurses to do, which is, you know, an ISCoS e-learning on bowel care and AD, booklets that I expect my nurses to do, and then it's all the practical applications and the session with the educational nurse. And they were like going, really, all that? And I went, but have you seen what it's asking you to say? It's asking that you are proficient in manual evacuation, digital rectal manual evacuation, that you are aware of all the pros and cons, and that you can teach a patient how to do it themselves. It's advanced, and they do the same with catheters. Is this staff nurse able to decide what's best bladder management for this patient? Can she educate them in, and can she do all of those bladder management? I'm like going, that is vast. You know, I don't expect my nurses to come out qualified like that. I expect them to learn it if it's in their speciality, and maybe, but I do feel that we will be used a lot more in the upcoming years to be dragged into universities to try and educate our nurses. And there is only 10 units in the country that do bowel manual evacuation as standard for their spinal patients. I don't think we'll get all the nurses through that are going to qualify. So I don't, because we send patients to step down care into Wales because they don't, they discharge to assess in their own areas. And I sent one to a hospital, and even the incontinence nurse and the bowel nurse didn't do manual evacuations. So they called in a district nurse every day in an acute hospital. And I was like, oh my God. So where's your succession planning for that situation? So we're definitely going to have an issue if we haven't done that. Then there's going to be an issue with intermittent catheters trying to start them early. But Wales are, I have to say, becoming more progressive. They've done a neuro rehab policy, which is working really well, and they're trying to transition that into spinal injuries and brain injuries. So I'm hoping we will see some more progression there.
I mean, just thinking about that succession planning part as well, Jeanette, the skills and experience you've got, because I know that I've spoken to so many clinicians over the years that say if anybody's got issues, they go to Jeanette on it, because when it comes to intermittent catheterization, you've pretty much seen it all, and you come up with a solution for most people. And that is such valuable knowledge to be able to pass on to somebody else.
Oh, definitely. Because what we'd like to do is get people to work with me, to work through alongside us, so that you can pass all that information on. Because a majority of my time is spent with bladder and bowels on my shifts. Majority of it, especially in the mornings, that's all I do is bladder and bowel all morning. Yeah, definitely. So
me too.
Oh, bless you.
Guys, I think we're pretty much up for time at the moment. I just want to say a huge thank you to you all for giving up your time and sharing this fantastic knowledge and experience you guys have got. That last topic we're covering there really shows the importance of actually being able to share this and get it out there. So thanks also to ISCoS for being able to get this out on this platform. For everybody watching, as part of Wellspect's partnership with ISCoS, we have a number of podcasts and webinars already published. So please subscribe to the ISCoS YouTube channel and put up the ISCoS podcast on your favorite podcatcher as well. There's a wealth of knowledge and information out there. You can also access free CPD certified educational content on the Wellspect Education website. And that covers everything from bladder management as well as wider continence care topics. So yeah, I would just like to say a huge thank you to you all again. And hopefully see you all soon. Thank you.
Pleasure.
Thank you.
Thank you.
Cheers.